We are happy to have with us Gali, Dr. Gali Lerman. Dr. Gali Lerman is the Chief Scientist Officer at Colton Center for Autoimmune at the Tel Aviv University. She's a biomedical scientist with a PhD in molecular genetics from Tel Aviv University. She specializes in translational research, guiding multidisciplinary programs that bridge basic science with clinical and commercial applications. She's a passionate advocate for women's health. Gali lectures on sex and gender conscious medicine at the Tel Aviv and Bar-Ilan universities, and she also serves as a board consultant to the Israel Society for Gender and Sex Conscious Medicine. Gali will talk today about AI at a crossroads, a catalytic for gender equity or a driver for deepening healthcare bias. Thank you, Gali, for being with us, and the floor is yours.
So thank you very much. I really want to thank Michal and Ronel and Nogafem for organizing this webinar and for all their tireless work they do to advocate for women's health. What my talk will focus on the buzzword you hear everywhere today, AI, but through the lenses of women's health. Over the past 2 years, artificial intelligence has rapidly entered nearly every aspect of our lives. In healthcare, this transformation has been especially significant. AI is now being used as a clinical decision support tool for physicians to analyze medical images, to assist in pathology, and even to support as a support tool for the patient themselves. And the question I would like to explore today is simple, but critically important. Will AI become a catalyst for gender equity in healthcare, or will it deepen the gender biases that have existed in medicine for decades? So to answer this question, we first need to acknowledge uncomfortable reality. Modern medicine was largely built around male body as a default standard. For many years, women were underrepresented in clinical trials. Female specific symptoms were often overlooked, and important biological factors such as pregnancy history or hormonal fluctuations and menstrual cycle were frequently just excluded from research. As AI become integrated into healthcare, it inherits the strengths and the weaknesses of the data on which it is trained. This creates both tremendous opportunities, but significant risks as well. Let me begin with the risks. One major concern is the growing use of large language models to summarize medical records and support clinical decision. Recent research has shown that this system may unintentionally reinforce biases already present in the medical documentation. For example, women presenting symptoms may be more likely to have their complaints described as anxiety-related or emotional, while men presenting the similar symptoms may receive more urgent clinical attention. If AI learns from biased historical records, it can reinforce those biases at scale. Another important challenge is data imbalance. Approximately 85% of healthcare AI projects suffer from some form of data bias. Many algorithms are trained on data sets in which women are underrepresented or where sex-specific data are not analyzed separately. Cardiology, for instance, provides a strikingly example. Women often experience heart attacks differently than men. Their symptoms may include fatigue, nausea, shortness of breath, or general discomfort, rather than the classic crashing chest pain more commonly described in men. When algorithms are trained primarily on male data, they may fail to recognize heart attacks in women. The problem is that these systems can still achieve very high overall accuracy. Why? Because they perform extremely well on the majority of population while performing poorly on a smaller subgroup. In other words, the model may appear successful while systematically failing women. Importantly, this bias is usually not intentional. It often results from a focus on maximizing accuracy without considering fairness or across different populations. Another challenge is the intersectional bias. AI systems do not only learn gender-related patterns, they can also amplify combinations of gender, race, ethnicity, socioeconomic status. Research has shown that AI models may generate different recommendations for patients with identical clinical features simply because they belong to different demographic groups. This means that women from a minority population may face multiple layers of disadvantages. And finally, we must consider data privacy. Today, millions of patients use Gemini and ChatGPT to ask health questions, 60% in 2026 compared to 21% 3 years ago. While this provides unprecedented access to healthcare knowledge, many of these systems are not protected by the same privacy regulation that govern traditional healthcare settings. As history has repeatedly shown, vulnerable population often bears the greatest risk when personal information is exposed or misused. However, despite these concerns, AI also offer extraordinary opportunities. For the first time, researchers can analyze massive data sets and identify patterns that were previously invisible. For example, AI-based analysis of cardiovascular disease have identified predictors that are particularly relevant for women, including pregnancy, complication, miscarriages history, and hormonal factors. These variables were often ignored in traditional models. AI can also address one of the biggest challenges in medical research, the lack of representative data. Research can now use synthetic data generation to create realistic data sets that improve the representation of women and minority populations. This approach may help correct historical imbalance and produce more adequate diagnostic and treatment tools. And there are already promising examples for that. In medical imaging, for instance, deep learning system use mammography that can demonstrate much improved detection of breast cancer, particularly in women with dense breast tissue, where diagnosis is often challenging. AI is also helping research analyze hormonal patterns and menstrual cycle data, allowing earlier prediction of disease flare-ups in conditions such as lupus and MS. In addition, AI-driven pharmacological models may help address another long-standing problem, women experience significantly more advanced drug reaction than men, partly because many medications were historically developed and dosed based on the average male body. AI models can help personalize dosing and improve medication safety as well as efficacy. So how do we ensure that AI becomes a tool for equity rather than a mechanism that reinforce bias? There are 4 key principles. First, we need diverse and representative data sets and design teams. Second, the models must allow physicians to understand how decisions are being made and how to spot bias on a real-time manner. Third, we need transparency and standard reporting for model performance across demographic groups. And the fourth, we need rigorous clinical validation before these technologies are implanted in real-world healthcare settings. So in conclusion, AI is not inherently fair or not inherently biased. It reflects the choices we make as researchers, developers, entrepreneurs, regulators, and healthcare providers. If we ignore historical inequities, AI may amplify them. But if we're intentionally design systems that recognize and correct these biases, AI has the potential to become one of the most powerful tools that ever created for advancing gender equity in healthcare. The future is not determined by the technology itself. It will be determined by how we choose to build it. Thank you.